there are upcoming PIPES events for the rest of the semester. There's one on medical genetics and genetic counseling in February. March is when they're doing the interprofessional simulation, so if you signed up to do that competition, they will be doing those at that time. And then in April, there's a sexual assault panel. So pick one of these up on your way out, and you can RSVP for those online. I'd like to introduce you to our panelists. We do have 4 people on the panel. One person does work till 5, so she will be here as soon as she can. And when she gets here, I will let her introduce herself. That's Kristin, but we'll start with, and everyone, we have a Kristin, Cristina, and Christa. So I know all of these lovely ladies, but if I make a little slip and slide, but Cristina can introduce herself first.
Sure. My name is Cristina Stauffer. I'm a social worker by training, and I'm an outpatient therapist. My specialty is in kind of all things women issues, including perinatal mood disorders and postpartum depression. I also do work around fertility, miscarriage, infant loss, and really just general adjustment to parenthood.
I'm Christa Peoples, and I'm a registered nurse and a lactation consultant. I work at Metro Health Hospital. I work in the inpatient postpartum unit, and so take care of moms and babies right after birth. I also lead our weekly breastfeeding support group, so I also see a lot of moms after they've delivered. They come back to the hospital for our support group weekly, and that's a lot of fun. And I also do individual outpatient lactation consults for moms that are struggling and need a one-on-one help.
My name is Emilee Van Hoven. I'm a physical therapist at Spectrum Health, and I specialize in women's and pelvic health, which includes a lot of women in the kind of perinatal period and really women throughout the lifespan.
Now, can everyone hear them? No. Okay. So we'll all speak a little louder.
Sure.
So first off, I'd just like each of you to explain, go in a little more depth about your role in healthcare as it pertains to women's health, and just kind of a brief rundown of what you do on a typical day.
You want me to start?
Okay.
Sure.
All right, let me know in the back if you can't hear me. I'll try to project my voice. Is that okay? Okay. I can stand up too if you want me to, but I'd rather sit. So as I mentioned in my introduction, I'm an outpatient mental health therapist, and so the population that I see are women in the childbearing years primarily, and I gave you a little taste in my introduction too of the kinds of things I address in my work. Before starting my private practice, I spent about 4 years in the mother-baby partial hospitalization program at Pine Rest as one of the treating therapists on that unit. So I feel like I gained a lot of expertise in the area of perinatal mood disorders. And so one thing we know is in the media, postpartum depression is kind of the umbrella term, but there's a whole continuation of perinatal mood disorders. And so what was most surprising to me as I kind of dove into this work is the amount of anxiety I actually see. Way more than the tearful, sad, withdrawn depression that you might think about when you hear postpartum depression. Lots and lots of anxiety. And along with that sometimes comes unwanted, intrusive thoughts that can be very scary. And women don't often want to talk about these symptoms that they're having. So it's really a passion of mine to provide gentle, safe, nurturing counseling, right? To help women understand what they're experiencing, help normalize it. A lot of what I do is education and validation and normalization. And it's freeing for women sometimes to come in and say, oh my gosh, I thought I was the only one. You mean this actually has a name and it's a thing and it's treatable? So that's kind of my passion. As far as what a typical day looks like, man, I don't know if there's a typical day. Every day is a new day, which is part of what I love too, right? I mentioned the intrusive thoughts. I do a lot of work around that in my practice. Women who are pretty terrified about, I have this new baby and all of a sudden I have all these what if thoughts, right? What if I drop this baby? What if something terrible happens? And those can ramp up to be pretty graphic and pretty specific sometimes. And then what do women worry about? They think they're developing postpartum psychosis, which is actually very rare, right? But that's what we see in the media, the horror stories, the scary things. And so that, I think, gets in the way of women reaching out for help. So again, sometimes I'll talk to women several times on the phone before they'll actually come in to see me. It's a real gentle, kind of nurturing, inviting. It's okay, we can work on this. And then once they engage in therapy, it's a combination of things. Again, I mentioned the education and the validation, but then from there, there's some real specific skills I can teach them too. What do you do when you have a panic attack? How do you get through the middle of the night? I mean, I think anyone who's had a new baby knows the middle of the night is a lonely time. Even if there's 10 other people sleeping in the house, when it's you and that baby, it can be really overwhelming and lonely in the night. So some concrete things about how do you get those thoughts under control? How do you manage that panic? The other thing we see is a lot of irritability and rage. For whatever reason, depression in that postpartum period, like I said, it's not usually tearful and weepy. I see some real irritability, and women who describe having a fuse about this short, right? It doesn't take much to just set them off. And so how do you manage some of those angry feelings? So I like to leave my clients with some concrete kind of practical skill-based things that they can use at home to get to those things, right? In addition to kind of the more traditional reflective counseling. Another thing that I do, and I do teach some classes in the community, is I'm an infant massage instructor, and so sometimes I incorporate that into my work with moms to help them feel like they have some control and empower them in doing something gentle and nurturing for their baby. It's a nice way to kind of help with attachment and bonding. So I can keep talking. Is that enough for now? Okay.
So again, I work at Metro Health in the inpatient postpartum unit. I don't often see moms when they come in initially into labor and delivery unless they have some specific questions immediately upon their admission. I usually see them sometimes within that first hour, though, after the baby is born. I will go into the labor and delivery room and help with that first feeding. My job is a lot of teaching and helping parents to recognize what is a good feeding, how to get the baby latched on correctly, how to know that baby is getting enough, because that's one of the biggest concerns that parents have is, how do I know my baby is getting enough to eat? So a lot of education, reassurance. My typical day is, I will get a list of all the patients on our unit, and the ones who are have chosen to breastfeed, I kind of do a quick health, a review of their health history to see if there's any risk factors that they have that might affect their breastfeeding. Kind of review how feedings have been going, and then go in and see moms and talk to them about how feedings have been going. What are their concerns? What are their goals? Are they going back to work? Do they have a breast pump? And kind of doing a lot of anticipatory, guidance and education too. Helping them with feedings if they need it. And then typically every day I see them until they go home. So a little bit of education every day to kind of get them ready and prepared to go home and breastfeed confidently. We also have a lactation warm line so that moms, once they go home, they know that they can call us 7 days a week. We're not available 24 hours a day, however, so the middle of the night, those are typically, unfortunately, when the struggles may happen, but we're available by phone. We get a lot of phone calls from parents with all kinds of concerns and questions. And then again, another big portion of my job is leading our weekly breastfeeding support group, which personally and professionally is very rewarding, because sometimes when I see moms for such a short time in the inpatient setting, to see them come back and to see their babies grow and to see their confidence as new moms grow, or to see, when they've had some struggles maybe initially, to see them overcome those is very, very rewarding. But just like Cristina said, our support group a lot of times is just moms who are isolated at home and they're home with baby, and to get out of the house and talk to other moms and to realize that some of the struggles that they're having are very normal and things that a lot of new moms struggle with. And to sometimes have different members of our support group who maybe this isn't their first baby, it's their second or their third baby, to impart some of their knowledge and their experience to some of the new moms is very helpful. So just like Cristina said, there isn't a typical day. Every day is a little different, but that's part of what I enjoy, is seeing new parents and meeting new people and new challenges every day. So
Thank you.
that's it.
So I think the best place to start for me is, what is pelvic floor physical therapy, right? I think it's one of those areas of PT that's like, oh, I'm sorry, you do what? So pelvic floor PT is a subspecialty of physical therapy that does require some additional training beyond the normal doctorate program. And so pelvic floor PT really hones in on looking at all of the musculoskeletal structures of the pelvis, specifically the pelvic floor, which is going to be the hammock of muscles that line that bottom opening of the pelvis. So in addition to that, we don't want to just know about the musculoskeletal structures, but how are all of those structures interacting with the other musculoskeletal structures in the area, like the back and the abdomen and the hips and things like that, but also all of our organ systems that are housed within the pelvis. So thinking about urinary, reproductive, digestive, things like that. So in pelvic floor PT, we really take a holistic look at what all is factoring into why you're having some degree of pelvic floor dysfunction. And as you can imagine, with pregnancy and delivery and things like that, the pelvic floor is in a really vulnerable state during that period. We think about all the hormones that are pumping through the body. We think about the fact that you have a baby or 2 or 3 hanging out on your pelvic floor for how long. The delivery process, whether it be vaginal, cesarean, all really takes a toll on that system. And then for women who are breastfeeding, a lot of times that dysfunction is prolonged because those hormonal changes are prolonged in the new mom as well. So pelvic floor PT, we see really a wide range of diagnoses. I think it's helpful to kind of, for simplicity's sake, divide those diagnoses into 2 categories. So you either have a pelvic floor that's not doing what you want it to do. It's too weak, it's not coordinated enough. So then when you see that, you're more likely to see symptoms like urine loss or incontinence, prolapse, organs sitting a little bit lower than they used to sit, things like diastasis recti, so that abdominal split with pregnancy, and more diagnoses similar to that. But then on the other hand, which I think is more of the category we don't think of as often, that's a pelvic floor that's doing too much. So that pelvic floor is not like this, that pelvic floor is like this, and it stays like this all day long. So you can imagine how sore that pelvic floor gets, right? So that causes kind of a whole other host of symptoms, which can also look like urinary incontinence, because a muscle that's already here can't make more of a muscle, right? So that woman might be leaking as well, but she may have pain with intercourse, she may have constipation, and things like that. And I'd be remiss to say, although I don't treat men, pelvic floor therapists also treat men, which is not the purpose of this talk, but it's something that I love to get the word out about, because I think a lot of people don't know about pelvic floor PT for women, let alone pelvic floor PT for men. But all of those populations are individuals who a lot of times are suffering from things that they think that there's no answer for. Or they, gosh, what you said about like, oh my gosh, you're telling me that this is something, like that this is a thing. Gosh, I think if all of us had a quarter up here for every time somebody said that, you know, just that reassurance of, I really do have something wrong, this is normal, and we can do something about it. I think that realization is so powerful. So my day-to-day looks like treating anywhere from 6 to 12 patients, depending on how long I'm working that day, and you know, it's really a wide range of treatments. So typical physical therapy treatments that you would think about, like strengthening and stretching and manual therapy and things like that. But also we use something called biofeedback at times, which is some external sticker electrodes on the pelvic floor, and it gives somebody a visual of what their pelvic floor is doing. Because it's not an area we're super connected to, right? Until all of a sudden maybe it's not doing something we want it to do. And so really helping to establish that brain-body connection through things like mindfulness and meditation. And then really, like these other ladies said too, it's a lot of education. I think my passion is really empowering women that, that there is someone who can help you on the journey to being empowered about your body, being able to improve your body, especially in that postpartum period where all of the focus is kind of on baby at that point. And so really bringing the focus back to mom and helping her just really empower herself to do something for herself.
So this is Kristin. If you can go ahead and just introduce yourself, what you do, maybe explain what a day would look like for you as a doula.
Okay, sorry for my late entrance. I was coming from my job. So I've been a doula between 4.5 and 5 years, and I never really imagined myself to be passionate about birth. I had a career in political fundraising before having kids, but it transformed me, and so I wanted to support other women. And so I am both a birth doula as well as an antepartum doula, so that's bed rest support. And I'm also a postpartum and infant care doula. So some doulas specialize in one thing, but I'm certified in all areas. So, the day in the life of a doula can be very different depending on what their specialty is, or, if they're like me and wear many hats, then it can vary. So we work with clients from essentially conception through the first year of their child's life. So clients may hire us the second they find out they're pregnant, or they may wait, like right up until delivery, or in the postpartum aspect, it could be, after baby's born. So yeah, we support our clients emotionally, physically, and with informational resources. And we are a judgment-free support system. So we really have no agenda other than to serve our clients. We are not medical professionals in any way. Again, it's more of a holistic, sometimes we're compared to a birth coach in the birth end of things. And obviously with the postpartum care, we're different than, say, a nanny or a night nurse, in that we're focused on the well-being of the entire family versus just caring for the child like a nanny would. So we want to make sure the mother's bonding with baby. We have a lactation consultant, IBCLC, on our team, but we just support basic breastfeeding and nothing beyond that. We refer out if they need additional help. And we support bottle feeding, pretty much all parenting styles. So, there is a misconception about doulas, especially in the birth realm, that we are just very crunchy, only attend home births. We support planned cesareans. We support medicated births, unmedicated births, hospital home birth center, you name it. So, and we love working at Gold Coast. We consider ourselves professional doulas. We're all either certified or working towards certification. We love working with medical professionals. Nurses are best friends. We love to work as a team with doctors, midwives, nurses, so the whole care team. But again, we don't overstep our bounds. We have a very strict scope, and we don't offer any medical advice.
All right, so I'm gonna start with Emilee first and just kind of get into some more specific questions. You already kind of delved into the pelvic floor dysfunction issues. Is there anything specific you wanna go into, like treatment options, anything like that you'd like to share?
Sure. Well, can I ask, does anyone have questions about different treatments or treatment options or anything like that? I kind of gave you like the rough overview. Do you guys have specific questions about anything? Yeah.
Where does one get a reference for a pelvic PT? Like, how do you get your clients?
Yeah, so I receive a lot of referrals from obstetricians in the area, gynecologists, midwives, doulas, chiropractors. All referrals will come from either a physician, a physician's assistant, or a certified nurse midwife. But in today's healthcare realm, there are several insurance companies who take self-referrals, and so not everyone needs a referral to come, depending on your insurance company. But a lot of times it's just asking your physician, so it doesn't have to be an OB-GYN or anything like that. It can just be your PCP. Most physicians are aware of it, but not all healthcare providers think of it as kind of like a first line of defense, which is how I think pelvic floor PT is best used. That's a good question.
Any other questions for her?
What kinds of like treatment options do you do for somebody who like say like if their pelvic floor is like spasming or like severely contracted?
Yeah, good question. So I always start just really gentle with those people. Normally it's like that for a reason, and so a lot of times there's a history of trauma of some sort, be it sexual trauma, be it labor and delivery trauma, something like that. And so we just start slow. A lot of times those people have been on a long road too. Women with chronic pelvic pain, the story I hear most commonly is oftentimes bounced around between providers, never really receiving an answer, several different surgical options, either explored or not explored yet. And so there's a lot emotionally built up behind that. And so just starting slow with that. And treatment-wise, I usually start with a lot of breath work because we know the diaphragm lines the bottom of the rib cage, yeah? And then the pelvic floor is going to line the bottom opening of the pelvis. And those two structures actually work in concert with one another, kind of forming a piston system. So as you inhale and the diaphragm descends and stretches, the pelvic floor is going to do the same. So then as you exhale, both of those structures recoil and rise back up. And so we can take a pelvic floor that's like this, and through breath work, working on movement of the diaphragm, we can teach that pelvic floor to kind of come back into concert with that system there. And so starting with breath work is a really great way, like we're not even approaching the pelvis yet, for women who may have a history of some trauma of sorts and things like that. So breath work is usually what I give first visit, no matter who walks in my door. And then on top of that, really working on just brain-body connection with the pelvic floor. As I said before, I think it's an area of the body, especially when trauma is involved or a long history of something is involved. But you just want to disconnect. You want to pretend like it's not there anymore. And so reapproaching that connection in a really positive way. So through some mindfulness, meditation, things like that. So not only do I think that's a great way to start from just a really gentle perspective, but we're going to reference those things throughout as we kind of ramp up our treatment. So we'll usually progress to some external manual therapy work first. So we'll do a lot throughout the inner thighs, we'll do a lot through the abdomen. All of that connective tissue there is continuous with the connective tissue of the pelvic floor. So I always say, if you think about it like one giant piece of saran wrap, if your saran wrap is pulled really tight in your legs and your saran wrap's pulled really tight in your belly, where did all that tightness settle? In the pelvis, right? So if we work in the abdomen and we work in the legs, we can kind of lend some slack back to that saran wrap, so to speak. And so then working in the perineum too, directly on that first layer of the pelvic floor. Pelvic floor has 3 layers. Layer 1 is more of your layer for blood flow and sexual function. Layer 2 is a lot to do with urinary function. And then layer 3 has a little bit to do with sexual function, but then they're kind of your big lifters of the pelvic floor. So that layer 1 we can get to externally. So really starting with some work there, and then once the patient's comfortable, doing some internal work of the pelvic floor as well. So if you make yourself a hand vagina and one finger, that's a little what treatment looks like. And so one of the biggest muscles we'll treat is actually in your hand vagina, what would be the pad of your thumb. And so doing to those muscles what I would do to a muscle in your neck or your shoulder. We might massage it a little bit. We might do a little trigger point release on it. I might have you move your leg around to get some blood flow to that area and things like that. So doing internal treatment from that perspective, and then using the biofeedback to try to create that connection between the brain and the pelvic floor, and a lot of things like that. Yeah.
Is physical therapy helpful with your endometriosis?
Yeah, it's very helpful. We do a lot of work in the abdominal cavity where a lot of that scar and connective tissue likes to settle with endometriosis commonly. But the other thing we see with endometriosis is that what's the brain's job? The job to protect the body, right? And so if we have an area of the body that's sore, if something abnormal is happening, the brain's going to say, hey, we need to protect this area. So muscles around that area, you guys got to go into like protection mode. So a lot of times what we see with endometriosis is that the pelvic floor has gone into protector mode. And so on top of endometriosis, you have a pelvic floor that's in spasm and is either causing pelvic pain or is referring pain up to the low abdomen. I think that's probably what I see most commonly with endometriosis is there's an assumption that all of this lower abdominal pain is due to scar tissue, when a lot of it is actually pelvic floor referral pain. That's a great question.
So you mentioned that the abdominal separation is something that you would treat. How does that tie into pelvic floor health?
Yeah, so if we think of our core, right, common word thrown around in fitness and therapy and lots of different industries, our core is kind of like a pop can. So if we think of the top of the pop can, that'd be the diaphragm. Bottom of the pop can would be the pelvic floor. And then the walls of the pop can would be our deeper abdominal and back muscles. And so when we think about diastasis, we've got the front of the pop can has like a big old split in the front of it, right? So that not only affects the abdominal wall, it affects all of those other structures that play into the pop can as well to create that stability system for us. So a lot of times with diastasis, we'll see the pelvic floor either do one of two things. Pelvic floor either like gives up too, like, well, if you can't do it, I can't do it. And so then we get pelvic floor weakness, or pelvic floor is trying to overcompensate for what the abdominal wall is no longer doing, or not doing well, or not doing as well as it used to. Make sense? Yeah.
Okay, we will, if you have further questions, we'll get more at the end. But I'm gonna go to Cristina next. If you wanna kind of delve into your role a little bit more, maybe your treatment options or anything that's out of your scope of practice that you refer out to.
Yeah. So I talk often to the women in my practice about kind of the 3 pillars of treatment, and those are, one is therapy, one can be medication, and one can be self-care. And I tell women that you can get better using 1, 2, or all 3 of those, but those are kind of the options to look at, right? And so medication is a piece that we talk about a lot in our work, and there are medications that are safe during pregnancy and breastfeeding. And it's a big weighing of risks and benefits when that comes up for women, right? And so in terms of interdisciplinary coordination, I talk a lot with PCPs or OBs, nurse practitioners. I have some people I refer to in the community who I can really trust that are well educated in psychiatric medications during pregnancy and in the postpartum period, right? Because there's a lot, I feel like the postpartum woman is kind of like a big puzzle, right? And there's lots of pieces to the puzzle, and everybody's puzzle is a little bit different. So providers need to look at that carefully, right? So that's a piece of coordination that I do. This is not professional coordination, but I do quite a bit of coordination with family members, right, to really talk to support system. Husbands and partners are a big piece of mom's success in those early weeks and months sometimes. And so that's part of my role too, that coordination. I coordinate with doulas. I coordinate with other therapists. In terms of, we're very lucky in this county because we have such a rich network of resources around perinatal mood disorders. And so I can help women understand kind of the continuum of services, right? Some women will do well on a low dose of antidepressant from their PCP or OB and maybe a support group in the community, right? There's lots of great support group options. Some women really like that weekly individual therapy like I provide in my outpatient practice. Sometimes women need something more intense if they really feel like they're in crisis mode, and that's where something like the mother-baby unit at Pine Rest comes into play, right? And I'm guessing that most of you are familiar with that unit, but the beauty of that unit is that it is day treatment, and women can bring their babies with them to that day treatment, and that's part of what makes it so unique. When that program opened about 5 years ago, we were only one of 3 in the country that incorporated baby into treatment in that way. And I'm happy to say that that has grown a lot. I think there's upwards of 12 now, which still is not enough, right? But it's progress. And so that is really what makes that unique. And another thing to say about that is that although women can bring baby to treatment, they don't have to. It's not a requirement. So if women would feel better, I mean, let's be real, it's not easy to go to a psychiatric hospital for services, and a lot of times women don't want to bring their babies to a psychiatric facility. That feels too scary. So it's really matched to what mom wants. So I like to always clarify that when I talk about mother-baby, because I think sometimes that's a misconception that they have to bring a baby with them, and they don't. It's really about what is best for mom, okay? And then the final kind of piece of that continuum is an inpatient psychiatric hospitalization, right? And that's really, because we have the mother-baby unit, that day treatment, that is really at this point for women who cannot be safe, right? Sometimes women who are having symptoms of psychosis need that intensive management, right? Or if they're having suicidal ideation or, you know, thoughts of harming themselves or someone else, they need that more intensive service. But what's beautiful is that they can step down out of that inpatient stay a lot quicker into something like the mother-baby program, where historically that inpatient stay might be longer. So that's kind of the broad continuum of services in this community, which we are so lucky to have, right?
One thing too, just a little pitch, if you're ever looking for volunteer work, you can volunteer at the mother-baby unit in the actual nursery, watching the kids there. So they're always looking for volunteers if you're interested in that.
Absolutely. I will say that people sometimes go into that role thinking, oh, I want to go snuggle the babies, which is part of it. But some of these babies are pretty dysregulated, right? Because moms are not doing well, babies are not doing well, which makes sense, right? So it's a delicate role as that volunteer. But if it's something that you're passionate about, it's a great opportunity for volunteer work, right? And sometimes it's helping mom to feel less inadequate, right? Because she hands that fussy baby that's so dysregulated to a nursery volunteer, and that baby calms instantly, and then mom just feels more defeated, right? What's wrong with me? And so it's emotional in that way, right? So I'm not trying to scare people off from your pitch, but those are the real things to think about, right? It's not just like rocking a baby in a church nursery. There's it's a real delicate dance sometimes. Yeah. But thanks for the plug, because it's important. It's an important role.
So I will go next to Kristin, and I just wanted her to explain a little bit more of why a doula is an important role in birth and pregnancy and postpartum care. A lot of you might not have heard what a doula is before, and then just some of the evidence-based practice around it, which we did hand out a sheet that's on everyone's seat, and it is related to doulas and the actual evidence-based research surrounding that. But I'm going to have Kristin talk about that.
Yeah, so much. Our biggest thing in all roles, whether it's bed rest support, labor support, or postpartum, is really to make sure that the laboring mother or mother in the postpartum time are coping well. So one of the biggest questions we ask during all of those stages is, how are you coping, and what can we do to eliminate fear, because especially with birth there's a lot of fear, or if they're on bed rest there's a lot of fear as well, and sometimes being a new mom or adding a child can create a lot of fear. So we're there to make sure that the family is coping well and give them resources and hands-on support, as well as information. And you all have that evidence-based birth handout on evidence for doulas. And with continuous support, there is evidence that we can decrease the time of labor, decrease the rate of cesareans. And obviously nurses and everyone else in the care team play a big role. But nurses and care providers have a lot of different roles, and as doulas, all we are there to do in a birth setting is to support. So we don't leave their side, and so we can reduce the rate of Pitocin and epidurals as well. So does anyone have any questions? Did you have a chance to review that handout? I don't know how far in advance everyone got that, or
It was just handed out.
just handed out, okay.
Krista, can I chime in about the postpartum piece a little bit? And I don't know if that's covered in this, but
No.
one of a big trigger I see for moms in the postpartum period, in terms of coping, is sleep deprivation, right? Sleep deprivation is not good, right? We know that, and it increases anxiety, and so I value that so much in our postpartum doulas in this community, because they do provide overnight care and can help moms and families get some good quality sleep. And so I just wanted to highlight that as you talk about the role of a doula, because for me, as I see, especially some of the women I'm treating in my practice, just so struggling with the sleep deprivation and getting on top of that anxiety, some good quality sleep is key, right? And oftentimes by the time I see them, they're so either they don't have a great support system or their support system is tapped out, right? People have already taken off as much time as they can take off. Partners are back to work, and so helping these women get some good sleep, a postpartum doula can be just such a gift.
Good point, Cristina. And not all postpartum doulas offer overnight support. Gold Coast, our entire agency offers it. So, and it can look different for every family. We, for bottle feeding moms, of course, then we wouldn't wake the parents. But for those that exclusively breastfeed, then we can bring baby to mom. She can nurse, and then we can do all of the burping, the diaper changes, and get baby back to sleep, so she's still able to bond and breastfeed directly rather than feeding the baby pumped milk. But even one night of good sleep can make a big difference, and in the postpartum role, we've even supported families where the mother might be going back to work and she's traveling, and they may have a toddler and a new baby, and so our overnight doulas come in and support the husband in his role, so he's not managing two different sleep schedules. And so, yeah, but it makes a big difference having overnight as well as daytime support.
Yeah. Is a doula a volunteer?
No, I mean, there are volunteer doulas in certain communities, but no, we are not volunteers in a professional capacity. Good question.
So people would buy a set of hours of support?
Yes, for postpartum support, it's based on an hourly rate. And then for birth support, it would be a package. And then bed rest support is hourly. It's very similar to postpartum support. Go ahead.
Do insurances cover doula?
Unfortunately not. Hopefully someday. We do, for birth support, we're able to accept certain HSA and FSA plans, but not so much for postpartum at this time. So hopefully in the future. Good question.
What are some techniques that you use during like the birth that you would use to support the mother?
Sure. Well, we go over what their birth preferences are and work to support those. So if they've taken a childbirth class like hypnobirthing, then that can look very different from someone who wants an epidural right when they get there. But we are able to support them again, make sure they're coping well with information, and if they like affirmations or prayer, for example, and their birthing, we can support in those ways. And then hands-on support, we can help with position changes, encourage them to move around if they don't, of course, have an epidural. And then we can give hands-on counter pressure, massage, and do a lot of physical support during labor and birth. Yes.
What does the certification process look like to become a doula? Like what classes do you have to take, or how long was it?
Yeah, so there are different programs. There are some online programs that take about a year to go through the coursework. Most doula certification programs give you 18 months to complete the work, and trainings could be anywhere from 2 full days, 2 10-hour days, to 4 days of, 4 10-hour days. And then as far as the process, every certifying body's a little bit different, but there's an exam, essays, readings, usually audit a full childbirth class, take a breastfeeding class, and also do some client reviews, medical provider reviews, nurse reviews, and so on in order to get certified. And then many organizations require a recertification every couple of years. In addition to other certifications, postpartum doulas are often, certainly in Gold Coast, required to be CPR and certified and maintain that every 2 years. So, does anyone else have any questions?
All right, we will move on to Christa. We do have a few more questions for her, both as a lactation consultant and because she's worked as a labor and delivery nurse before. So we do have a lot of nursing students here, so if you could maybe go into just a little bit about your role as a LMD nurse. Former.
I graduated from Grand Valley. I'm a Grand Valley alum about 20 years ago. And first of all, I worked med-surg right after I graduated. I always knew that OB was my passion and my love. I volunteered and was an extern while I was in college in OB. And again, it's been in my blood, I think, since I was little. So shortly after I graduated, again, I took a med-surg position, worked that for about 8 months, and then started working in labor and delivery. A lot of on-the-job training. I think I had an orientation period of, 3 to 6 months. But worked labor and delivery for many, many years and really enjoyed it. My job as a labor and delivery nurse is, taking care of the mom and the dad and the support people and really supporting the entire family. In some regards, kind of like a doula. Being at the bedside, we have other responsibilities, the medical responsibilities of administering medications and checking vitals and all of that. But really supporting mom's wishes, what her birth plan is, and helping her with different positioning, comfort measures, breathing techniques, and even for couples who have gone through childbirth preparation classes, a lot of times in the stress of that moment, sometimes that information gets lost, and dads feel, even though they have taken some time to prepare, they rely a lot of times on the labor and delivery nurse to kind of help guide them through that path during childbirth. I also have worked labor and delivery and postpartum in both of my jobs, both of the hospitals that I worked. So I would also take care of moms and babies during the postpartum time. So again, attending to her physical needs, medications, a lot of education, newborn care, mom care, postpartum breastfeeding, bottle feeding, everything about the newborn and mom care after childbirth. I became a certified lactation counselor about maybe 7 years or so into my labor and delivery and postpartum career, and that was a week-long course that was a lot of classwork, coursework with an exam at the end. And after that period, I started teaching prenatal breastfeeding classes, leading a breastfeeding support group, and really appreciated the opportunity to know more about breastfeeding so that I could better help the parents that I worked with. About 5 years ago, I had always thought about becoming an international board certified lactation consultant, and finally decided, it was time to do that. And so I took the international exam, and now for the last 4.5 years, I've just been exclusively working as a lactation consultant. I don't do labor and delivery and postpartum, even though I am there in that facility. Lactation is my sole role now. What else? I'm sorry.
No, that's
Tell me
it.
again. What do you?
Yeah,
where
but we
did
were
you want
gonna
me to?
also delve into, because there's pharmacy
Yeah.
students here, a little bit about breastfeeding and medications, and then tongue ties for our
Yeah.
speech
language pathologist.
So, my job as a lactation consultant really is easy if a baby will latch on comfortably for mom. Mom is very comfortable getting the baby latched on fairly independently. Mom has plenty of milk, baby is able to transfer that milk very well. That makes my job very easy. However, for a lot of women, there's something in that process that can be challenging. Whether mom has some anatomy that can be difficult to get the baby to latch on, baby during birth process, and for a lot of different reasons, sometimes cannot suck correctly. The whole birth process can be very traumatic for a baby, both vaginally and by cesarean. And so if the baby doesn't want to open his or her mouth very wide, doesn't know how the coordination of the tongue movement and the jaw movement to effectively remove milk from the breast can be a problem. So a lot of my job is figuring out where the problem lies. Is it mom's anatomy? Is it baby? Is it that mom maybe has some hormonal, underlying hormonal issues that make the process of actually producing milk difficult? So we have to sometimes determine or help parents figure out what a good plan, an alternate plan is to feed their baby while continuing to promote and protect mom's milk supply. So if baby won't directly latch onto the breast, then doing some hand expression initially in the beginning to remove milk from the breast, or having her start pumping with either a manual or an electric pump. And then certainly we need to feed the baby, and so doing that in a way that helps to promote the breastfeeding, so that if we can get that baby sucking correctly, we can get mom's milk coming in. The goal is eventually, if that's mom's wish, to bring the baby back to the breast, that we've done it in a manner that will help facilitate that. So that is where my job can be a little bit more complex, is figuring out, again, what can be the problem, and what's the best plan to go about that in the meantime while we continue to kind of work on it. We do a lot of, as far as interdisciplinary planning, we work a lot with our pediatricians. We have, at Metro Health, we have osteopathic doctors. We have doctors that specifically specialize in osteopathic medicine, which is a specialty that, the big umbrella, because I'm not an OMM doctor, just to kind of a general understanding is that if the body is in good alignment, if muscles can relax, blood flow is better, nerves are not impinged, so all of that can help a baby to latch on, suck correctly. So we do a lot of referrals to OMM. PT sometimes down the road can be an option too for babies that don't suck correctly. We sometimes nutritionists, if moms have some certain dietary restrictions, figuring out what would be an appropriate diet for mom. If babies are, if we're noticing that baby is struggling with something in mom's diet, referring her to a dietitian to kind of help her figure out some alternative diet plans for her. Medications, a lot of, we get a lot of questions from both moms and from physicians about what medications are safe with breastfeeding. There are a lot of medications that are very safe with breastfeeding. Like Cristina said, a lot of antidepressants and psychiatric medications. Certainly we have to weigh sometimes the benefits and the risks, but there are a lot of options for moms, and unfortunately sometimes, if you read the label of any medication, it'll say do not take if you're breastfeeding or if you're pregnant. Well, that's kind of just a real blanket statement, and there's a lot of things that are really safe to take. And sometimes moms unfortunately get some incorrect information. Sometimes moms who have had general surgery or general anesthesia for maybe their gallbladder being being taken out postpartum will be told that they need, from the anesthesiologist, that they need to pump and dump their milk for 24 hours because they've had general anesthesia, and that's not accurate. So a lot of times my role is talking to physicians and letting them know that there are a lot of options when moms are breastfeeding, and because unfortunately physicians don't get a lot of education during medical school on breastfeeding, and so that can be a big part of my role. I do a lot of education with our OB residents, talking to them about breastfeeding and how they can help moms during the antepartum and postpartum period when questions arise about breastfeeding and lactation. So that again is part of my role as well. So.
Do you have anything about tongue ties at all?
Yep, tongue ties can be a challenge. A tongue tie is the technical term is a linguinal frenulum. It's a piece of tissue that runs vertically up and down underneath the tongue, and sometimes it can be very tight and very short. There's different degrees of tongue tie. Some babies will have that linguinal frenulum attached right to the tip of their tongue, and it's very short, and so that limits or it anchors the tongue so that babies cannot extend or lift or cup their tongue, which can impact baby's latch and the ability to remove milk effectively from the breast. Sometimes it can be longer and a little bit further back on the tongue, and it may have no impact in the breastfeeding at all. But some of the things that we will see if a baby is tongue-tied is when the baby's crying, you can sometimes see that very easily. It'll look like a little string of tissue. Babies oftentimes will have difficulty in latching and being able to sustain a good latch and good suction at the breast. Moms will have sometimes a lot of pain with latch because the baby cannot get on deep enough onto the breast. Babies aren't gaining weight appropriately because, again, they can't remove milk well from the breast. So there are a lot of different treatment options. Sometimes that tissue will just stretch. There's some techniques that can be used to just get that tissue to stretch a little bit over time, but sometimes it needs to be cut, and so sometimes clipping it or using cautery to cut that tissue to release the tongue. But I have seen babies that sometimes have been tongue-tied and then that tissue is clipped. And then sometimes kids still don't know, now that tongue is freed, they don't know still what they're supposed to do with it. So it can be sometimes a work in progress, even though that tongue has been released. A couple other classic signs that sometimes you'll see if a baby is tongue-tied is when they do try to extend their tongue. Again, sometimes it cannot even extend beyond their lower gum. It will kind of heart shape or indent right along the tip, so it'll kind of almost look like a snake's tongue. Again, usually you can see it. They are real sloppy feeders. They just can't get good suction at the breast. Even with a bottle, they sometimes are real sloppy. The milk will kind of just run out of their mouth because they can't get a good suction on the bottle nipple. Sometimes babies, they can't hold a pacifier well in their mouth. And it's not because they don't want the pacifier, they just physically cannot create the suction to hold on to the pacifier. So those are some of the things that we see, and again, sometimes we have to figure out an alternative feeding method if either breastfeeding is too painful for the mom and the baby just cannot latch on. Then again, sometimes we have to do some pumping and some alternate feeding, whether it's by cup or by syringe or by finger feeding, or sometimes just with a bottle until we can get that revised.
The last part of this before questions is going to focus on interprofessional work, because that's what PIPES is about. So you guys have done a great job already talking about referrals and who you've worked with, which is great. But if any of you could share maybe about any challenges that you've had with other disciplines that you'd like to share, or what you would like other disciplines to know about your role that would help, the patient and their family. Emilee, do you want to start?
Sure. So I was thinking about this question. I was like, what is the challenge? And I honestly think that we're all so dang busy. Like, we all have packed days, so to have time set aside to communicate with one another besides anything other than email is hard. And so I think the best solution, and there are opportunities like this in Grand Rapids because we do have just like such a beautiful nest of women who are dedicated to this area of health. But like get-togethers with other professionals, I think, is great for that communication piece, just the opportunity to talk face-to-face about different patients that you see and different diagnoses that you see, and just really gaining a good understanding of what everyone's expertise and role is in the team. And then, what was the second piece of the question?
Well, do you have anything that you would like other health disciplines to know about your role?
Yeah, so I think a lot of times pelvic floor PT is, especially in the postpartum period, it's like, oh, sex is painful. Let me know when you stop breastfeeding if it's still painful, and then maybe we'll send you to PT. Or, oh, you're leaking a little urine. Let me know in a year if you still are, and then we'll send you to PT. In France, it's actually standard of care that every woman after a baby gets 6 visits with a pelvic floor therapist. Like everybody, it's just a part of what you do. So my hope would be that we can transition to that in Grand Rapids, because we are really unlike a lot of other areas of the state and the country that we have this pocket of pelvic floor therapists who all have busy schedules, but who are really passionate about this population. And so for OBs to just know, like, oh no, we're not gonna wait a year, I'm gonna send you right away. And that's what the research supports. And you see the evidence for almost every diagnosis that I've mentioned so far, that pelvic floor PT should be the first line of defense once anything medical is ruled out. So surely we're ruling out anything that would, you know, be a red flag of sorts. But after that, pelvic floor PT should be first. So it should be before medication. It should be surely before a surgery. And so that would be just what I would hope that you guys would take on as healthcare professionals. Like, no, we're not, well, if this doesn't work out, we'll try pelvic floor PT. No, like research supports, like that's what you should try first. And if that doesn't work out, then let's try something else. And so that's what I would just encourage everyone to kind of take with them about pelvic floor PT.
Cristina?
It's interesting, as I thought about this question too, in terms of challenges, my first thought was exactly what Emilee said, is time, right? We are all so busy. But I'm going to echo a little bit about what you said too. People who are passionate about this work are such joys to coordinate with, right? Even like as the three of us got to know each other when we first got here, we all just agreed that each of our own individual specialties are so needed. And so we are very lucky in this community to have such a rich network. I would say one thing that comes up in the postpartum world of screening is I still think there's some work to be done with pediatricians and pediatric clinics. Not because they don't want to screen moms for postpartum, and in fact we're seeing a great improvement in that, but it creates a dilemma for those pediatric practices, right? About mom's not really our patient. And so if we screen her for postpartum depression, then what is our responsibility in terms of referring, and what do we do, right? And so I see that dilemma, and time becomes part of that dilemma as well. But again, I've seen a lot of pediatric offices step up and start to screen moms regularly. I know this is a passion of Nancy Roberts through Spectrum Health and Healthier Communities. I know that our local perinatal mood disorder coalition has taken on some of this, and so that's one example I see of where we could do some better coordination. And I know the Pine Ross program for the Hope Line, and certainly myself as an individual clinician, we're happy to be resources, right? And if providers have questions or are worried about maternal mental health or perinatal mood disorders, I want people to call me, right? Even if it's not about coming to see me, I'm happy to make those connections.
Just a little something off that too. I actually just recently went to Nancy's. She had like a day session on the perinatal mood disorders, and she did talk a lot about that women should be screened for these anxiety and mood disorders more than once. A lot of it could be at the hospital where they're given a quick form after they've just had a baby, or at that 6-week checkup. But women can not have any of these symptoms until well after the baby is born.
And that's where the pediatric providers almost become the first line of defense, which they're the ones seeing these moms regularly for the well-child visits.
So I mean, I would just encourage you, if you're working with a postpartum mother, not just to think about those first initial few weeks, that, look more into long term.
Yeah, throughout that first year of postpartum.
What would be the recommendation for that screening as to how far postpartum out you would want? Would it be like every well visit for X amount of time?
Probably for the first year.
Okay.
Yeah, I mean, ideally. It's at the mother-baby program at Pine Rest, I mean, they are just currently treating women up to 3 years postpartum. And oftentimes, it's not that the disorder has developed that late, it's that it developed really early on and never was treated, right? So it's just gotten worse and worse and worse over time. And so I think, that kind of regular screening, it's not gonna hurt. It's still gonna be accurate, even if you're 12 months postpartum, even if you're a year and a half postpartum. It's gonna pick up some of those triggers. Does that make sense?
Kristin, if you'd like to go ahead and.
Yeah, so in an unregulated industry, doulas are not required to attend a training, be certified. So anyone can call themselves a doula, essentially. They could be trained by another doula. So for me, there's a lot of challenges because there are often negative views of doulas in the medical community because they might have had an experience with someone who could have even been a friend and called themselves a doula, or who was trained traditionally, or who may have attended a training for 2 days 10 years ago and never completed certification, never kept up with it. So my goal 2.5 years ago in starting Gold Coast Doulas was to raise the standard of professionalism. We have liability insurance. Most doulas do not. We require doulas to be certified. They carry their own insurance. They're subcontractors. They all have their own businesses that we pay them out to, so they're paying taxes. Again, we're elevating the profession by doing those things. We wear name tags with our credentials, so nurses and providers know our names, and by having certification, there's a body that if there is a grievance, if something happens in the home or hospital, there's a place to go to, complain essentially about your doula if they did something that was out of scope and acted in a medical way. There are always the rumors around town in the doula community about a doula who, locked her client in the bathroom and the doctor couldn't get there. And so we fight a lot of this, and there were, hints of doulas being banned. And so we go to provider meetings if an OB has not worked with our team. We meet with them and we work hard to create relationships in the community and have respect in that way. So that's our biggest challenge, I think, is the fact that there aren't boards and there's not really any overriding body for doulas.
How frustrating for you.
Yeah. It's very frustrating.
Christa?
I think, one of the biggest things that I wish that all, the gems that I've learned over the years is listening to moms and really, truly listening to what they're saying. I think one of the frustrations for me is that sometimes I will see a mom maybe 5 weeks postpartum, and she's been having pain with her baby latching since day one, and baby hasn't been gaining weight, and maybe her provider said, well, breastfeeding's supposed to hurt, and your baby's gaining weight okay, well, the baby's always fussy, and so she's struggled and struggled and struggled for 5 weeks until maybe then finally she comes and sees me. And in an ideal situation, again, having a lactation consultant to really assess breastfeeding right from the get-go, and then ideally in the pediatric office, for one of those well child checks, at 2 days after they go home from the hospital, at 2 weeks, to identify if there are any issues so that we can catch them early so that moms don't struggle, because a lot of times struggles with breastfeeding can turn into, or then start to turn into issues with postpartum depression and anxiety, and sleep deprivation is huge. I see a lot of moms who come into sometimes our breastfeeding support group who have been struggling, and now they're so sleep deprived, and it's really, really difficult. And I feel really bad because I think had things been different weeks ago, maybe she wouldn't be on this still struggling. So I really appreciate physicians who, recognize and listen to moms when they really feel that, their gut's telling them something's not right, and to make those referrals. And sometimes just owning up and saying, I don't know what's going on. And I say that a lot of times too to moms. I watch a baby feed, and sometimes I just can't put my finger on what it is that's the problem. But letting her know that I hear what you're saying, I see what you see, and I'm not quite sure how to fix it, but let's, figure out a plan. Let's kind of try some different things, and sometimes it is kind of trial and error and seeing what may work and what can help her in that moment.
So the rest of the time is going to be for questions. Does anybody have any questions at all?
Can you speak to providing breastfeeding support for a baby with a cleft lip, or is it just standard to keep an OG until they have surgery?
And then can you repeat the question, just so everyone can hear?
Yes.
Up at the front.
So the question was about lactation support with a baby that has a cleft lip and cleft palate. We try to put the baby to the breast, a baby that has a cleft lip and cleft palate. A lot of times babies can breastfeed better than bottle feed because the breast can kind of fill that gap and they can get better suction. But a lot of times, even if they can latch on and get suction, the concern is, do they still have enough suction to effectively remove the milk from the breast? So a lot of times we still will have moms put the baby to the breast, but then kind of do some what we call insurance pumping afterwards to make sure that we're still adequately stimulating the breast and protecting the milk supply, and sometimes then doing some complementary or feeding the baby with an alternative method to if the baby is not gaining weight appropriately.
So I know the postpartum period can be just so crazy and so hectic, and a lot of moms are put on restrictions against even being able to drive for a period of time. But establishing that breastfeeding relationship is so important early on. Are there any sorts of services available that can come to moms for and there's different levels of lactation, like consultant and counselor? Can you explain those a little bit too?
Yep, there are peer counselors. WIC has some breastfeeding peer counselors who don't have any specific certification but can sometimes help with breastfeeding problems. There are certified lactation counselors, CLCs, which have gone through a week-long course with an examination for certification. And IBCLC is kind of the, I don't want to say the top of the list, but the international board certification, and it again requires contact hours, classroom work, helping moms direct breastfeeding experience with hands-on experience with mom, and an examination. And there are insurance will reimburse for an IBCLC, a referral to an IBCLC. So like when moms are referred to us for an outpatient consult in the hospital, insurance will cover that. There are some pediatric offices here in the Grand Rapids area that have lactation consultants in their office, so they can bill for those services. Moms, there are a few lactation consultants in our community who do home visits. There's not a lot of them. There's one through Gold Coast. There's a couple of them in the community. They can bill for through insurance. I think Shira, does she?
She can do a super bill, but
Yeah.
we don't,
You
she
don't,
doesn't
okay.
deal with insurance
Okay.
under our umbrella, so.
Okay. But I think they can turn around and submit that bill to their insurance for reimbursement. But that is a struggle, when moms go home from the hospital, if they don't have a lot of family support at home, and now mom's home alone and she's struggling with the breastfeeding and she can't drive for 2 weeks, she's gonna need somebody to drive her to a support group or to go see the lactation consultants. And so yes, in the ideal world, that would be wonderful to be able to see a mom in her home environment, to see, what other factors are maybe impacting her breastfeeding. What kind of chair does she like to sit in? Having her use her own, seeing her in her own home environment would be ideal. But yeah, there aren't a ton of those services available, unfortunately. Good question.
So it's a little different, but Spectrum House Med now does offer lactation video visits.
Yes,
Yeah.
they do.
Yes, so that's not entirely the same as an in-person, but
Right.
that could help them
Yes,
get out.
she was saying that Spectrum does video lactation consults. And certainly that is, at least something. It still is hard because the lactation consultant can't still touch and feel and really do a full assessment, but it sometimes can be helpful for some problems.
I'm not sure.
I don't know.
Sure.
I just have a question about dietitians and maybe your role with them. We're clinical dietetics here, and you might be the minority here. I'm just curious kind of about how often you work with them, like how you view their role, if you refer them, or patients to them only when something's wrong, or how common it is for you to work with them.
I don't that often. I know through WIC. Sometimes moms will more through the WIC program, but not a ton in my role. I've talked to moms about maybe seeing a dietitian when they're really struggling with some dietary issues and breastfeeding, but not a whole lot.
Okay. This is for the PT.
Yeah.
Do you ever struggle with pushback from mom, or kind of her being uncomfortable with? Because I know when most women think of the pelvic area sexual, do you ever get any women who are resistant to treatment, or how do you make them comfortable with that?
Yeah. I think that's a great question, and I think that's a stigma that's certainly out there, especially in light of, the trial that's going on with Larry Nassar, who was doing some things that sound probably really similar to things I was describing, but were surely used in an inappropriate way. I just always view my role as educating, so educating mom or any patient I see on treatment options, what I would choose as the best course of treatment given her presentation, and then just meeting her where she's at. So I surely will see patients, and I'll never do internal examination or work on them. And I just always make sure that they're educated to know, I can't know for 100% what's going on with your pelvic floor unless I do an exam. I can take some of the symptoms that you're describing to me, and I can take what you're comfortable with me doing externally and try to piece some things together, and we can see how far we can get. So that's just how I view my role, is I just want to meet anybody where they're at. And so sometimes women come in and they're like, if you don't do an internal exam on me this first day and tell me what's going on, I'm walking out and I'm never coming back. And then, like I said, in some women, I'll never do an internal exam or treatment on. And so I'm comfortable treating, either end of the spectrum and everyone in between. And I just think really it's all building a relationship, and I think that anyone up at this table would probably say the same thing, is just building that relationship and that level of trust, and just really working as a team in their care. And so making sure that, I'm not just the treatment provider. I like to think of myself as more of a facilitator, so I'm trying to empower her to do things as well. That's a great question, thanks.
It's Emilee, right?
Yeah.
Okay, so is there a point, I guess, of no return? So if you have a mom and she comes, she doesn't come to you, and then she goes on to have multiple children, and then all of a sudden she comes back, can that all be kind of reversed, I guess you could say? Or is it just it will just get worse and worse, and then it's not gonna get better?
It really varies. It varies pregnancy to pregnancy, person to person. Some people have more natural recovery after pregnancy. Some people need a little more facilitation in the recovery after pregnancy. And so that really does vary. In terms of your question of, is there a point of no return? Of course, I'm like the biased pelvic floor therapist. We're like, no, there's no pelvis I can't treat. So, that's what I like to think. And so No, I don't think that there's a point of no return where it's like, oh, well, I'm not even gonna send you to a pelvic floor therapist because, you for sure just need surgery unless a surgeon assesses them and says, no, medically, you need surgery, like, you're going to suffer some negative consequence if we don't do this, in the immediate future. But no, I think that there's always room to at least give it a try and see, research supports. Like I said, it really being the first line of defense for things like urinary incontinence. In terms of prolapse, we have a five scale grading system for prolapse, so any organ that's just sitting a little low. Research supports being able to change that prolapse grade by 2 grades, which for a lot of women puts them in a place where they're not symptomatic, which is great. So no, I don't think that there's a point of no return. Did that answer your question? Yeah.
We have time for probably one more question.
Hi, is it Kristin?
Yes.
Yeah. Okay, so is there a movement right now to try and standardize accreditation for doulas? And if so, how can other members of the healthcare team help kind of push that movement forward so we can utilize you as a resource more frequently?
I have not heard of one. There obviously have been movements to accredit midwives, so home birth midwives and so on in Michigan. I haven't heard of anything, even in other states that doula friends of mine live in. Certainly, the biggest movement with doulas is there are a couple states that do cover doulas with insurance, Medicaid specifically. So that would be the biggest movement in the doula community, would be to try to get coverage. But I would love to start something to get more respect within the medical community for sure. It's needed. If you have ideas, let me know.
Any other questions? Probably one more. Go ahead.
I feel like I've asked too many, but I have a question for you, Cristina. What can medical workers at large do to help reduce the stigma around all of these postpartum symptoms? Because so many moms just feel bad about themselves and they don't want to talk about it, even to their doctors.
Yeah, I think, I really liked what Christa said about listening, right? Just really not minimizing what's going on for women, right? Listening is so important. And normalizing, right? Helping women to understand that sometimes anxiety and depression happen either during pregnancy, in the postpartum period. It does not mean they're a bad mom. Women are afraid to come and ask for help because they're afraid CPS is going to get called, right? Or someone's going to take their baby. I don't know how many of you have seen this recent article, I think I saw it on Facebook, about a woman who called her OB office for help and they sent a police officer to escort her to the ER. This just happened recently. And that talk about stigma, who's going to want to call, right? As soon as I saw it, I was like, oh no, like that's the wrong direction. That's not where we want to go with this, right? So I think as providers, having some basic understanding of the continuum of perinatal mood disorders is important, right? So you can validate and reassure some of those symptoms and then refer to good treatment. Which again, in this community, we're lucky to have such a range of options. A lot of communities don't have as much specialization. So my rule of thumb for other counties or more rural areas is Postpartum Support International is a great resource, a great website. They will connect you with regional coordinators and help you find resources close to your area. There's even some online support available now. Does that help?
Yeah.
Good question, thank you.
One more. Then we can ask questions when we're done. Go ahead.
Whenever someone seeks out your guys' services, what's the best thing father or baby can do, or the dad in the situation? Do they go to therapies, or
That's a great question. I mean, dads and partners are such an important piece of women's success. I think all of us would agree with that,
Yes.
right? Breastfeeding, labor and delivery, involved partners are great. But I think it's important to realize there are resources for dads too, because sometimes dads struggle. And in fact, we know that up to 10% of men can have symptoms of perinatal mood disorders themselves. And that's not as hormonally driven as it is for women, but adjusting to a new baby is a huge adjustment, right? So it's not unusual to see men have some symptoms of depression or anxiety or just adjustment. In this community, Spectrum Health, Healthier Communities does a weekly postpartum support group, and once a month they have a special night dedicated to dads. Although partners are always welcome to come, they really try to make a separate group facilitated by a male counselor so that dads have support too. Personally, I welcome dads into my sessions with moms. I think it's really important to have dads understand what's going on, understand what to say, what not to say. So it's a great question. Dads are really important. I know, Kristin, you're passionate about including dads.
For sure.
Too.
Well, thank you guys for coming. We really